Go ahead, Nabil.
All right. So good evening for you overseas. I'm really excited to share with you the second part of discussing what is new about the management of sepsis and septic shock. As you recall, we discussed in the previous part one of this lecture about how to manage patients initially, how to resuscitate them. And the two components were, well, the three main components we discussed before were managing fluid, managing vasopressors, and giving antibiotic timely. So these are sort of the three core items that has been in every guideline. So I will sort of go back on a couple of points today. I think we will have a less number of slides, so hopefully we'll have more time for discussion and questions on your side if you have any. So with this, I wanted to show you this. This is something that if you want to look at the literature, I would like you to pay attention to this, what's called, what's happening in the past few years. And this is only looking from 2000 to 2012. This is looking at sepsis mortality, and you can see that gradual decline. Now, this gradual decline, is it related to the protocols, or is it because we have better critical care, because we can manage patients overall better? I think there's a lot of factors. So when you compare studies, I want you to be aware that if you compare the RIVER study, which is the original early goal therapy, and look at 60-day mortality, you'll see how mortalities between the two groups were significantly higher than the later studies that were done here, which also looked at mortality at 60 days. And you can see almost half, whether you're doing early go, whether you're doing standard of care. So when you compare, whose trial represent the truth, we see here this trial showed significant difference by doing early goal over control versus the newer trials. Now they're about 10 years old, but these were the most recent ones. And you can see that here there was no difference, but everything was better. So always we need to look at these things and say, as of today. Now, again, I think a lot of you who practice in the ICU probably would agree with me. We, in general, septic shock doesn't really have 20%. I think we're somewhere in between, but I think 30–40% mortality. So these were highly controlled studies, university settings. Patient had to meet a lot of inclusion criteria to go into these studies. So that's why I think these are better than the average regular hospital ICU septic shock type of patient. So these are better than real practice medicine. So with this, now we usually sort of, this is going back to the choices between fluid and antibiotic and vasopressors. So I usually like to ask that question if you're on a deserted island and you only have a choice between one of the two, and that boat's passing by and you're having septic shock, and they tell you you can get only one item. What would you get? Would you get IV fluid if you're hypotensive? Or would you get antibiotics? And again, that's in life, sometimes you don't have too many choices. So this is a study I feel I'd like to share with you, which is more important, fluid or antibiotics. And this is, again, related to the first part we discussed. So this is called Time to Treatment and Mortality During Mandated Emergency Care for Sepsis. So again, this is not the way, it was not a randomized study. This is a large number conglomerate of data from a large database. And they looked at patients' outcome with septic shock who received fluid and antibiotic, and they wanted to see correlation between time and outcome. So if we look here and we look, does it matter when the patient gets the initial bolus of IV fluid? And this is called risk-adjusted or crude mortality. So the risk-adjusted is the more reliable, and this is time to completion of the bolus. So if you get your bolus of fluid and look at hospital mortality on this graph, you'll see, whether you get it in the first hour or 2 or 6, it doesn't seem to change the outcome. And again, these are collected data. These are not randomized trial, but fluid doesn't seem to make an influence on mortality based on the time of completion of the fluid bolus. On the other hand, if we look at antibiotics, the timing for antibiotic, and again, I always say what really causes sepsis is bacteria. So if we always think about the source and we look at, how can we manage the source of the sepsis itself, not the consequences, then the antibiotic would be the actual treatment for sepsis. And here is septic shock. You'll see that there is this linear relationship. The later that you give antibiotic, the worse is the outcome. So mortality tends to rise over time as we delay giving antibiotic from the time of onset of symptoms. So if you look at that and look at the earlier study, Canadian study by Kumar, that about 7% per hour based on what happened to the patient mortality. This is probably more realistic study. So the antibiotic made about a 4% per hour difference in mortality. So every hour delay based on this study would give you a worse outcome or increase in mortality by 4%. Previously, the earlier study was 7% per hour. So this is probably more realistic. And again, that reflects the first graph I showed you. Things are better, and outcome of patient in general in the ICU is all better. I think we're providing better care overall. So now there is a situation related to, what would you do if you have a patient, what we call refractory shock, and your blood pressure is, not improving, your patients, you've done, your fluid resuscitation. So these are sort of a checklist about, this situation where I feel like, why my patient not responding? What else can I do? So I put here first, and this is something I can tell you, every item I'm listing here, I have seen it in clinical practice, and some of you may have, but sometimes your measurements with the cuff pressure is not accurate. So I'll put an arterial line. So anytime you have refractory hypotension, it's not easy when they're hypotensive, but it is necessary. And now the guideline recommend insertion of arterial line. And I've had patients who looked well, but the blood pressure was extremely low on the cuff. And then we noticed that there was like 20, 30 millimeter difference. So always put an arterial line in those difficult to manage patients. Change your vasopressor. So as we mentioned before, particularly if you're maxing out on your levofed dose and you're reaching more than 0.7, close to 1 mic per kg, then this is the recommendation is to switch to something that has this combined alpha and beta. So epinephrine would be but it is what I would call the last resort. This is before adding the vasopressor. Now, always think of right heart failure. And this is an entity we may not recognize, but they are those, a lot of you now are trained by doing bedside echocardiography. So you need to look for that, either that the patient may have undiagnosed pulmonary hypertension, and every now and then we see those patients for various reasons. Most of them are obesity, hypoventilation, or chronic COPD, or those patients that we induce right heart failure by providing very high ventilatory pressure, particularly high level of PEEP. So those patients would fail for that reason. So you need to do a bedside echo on those patients. Now, again, if your patient not getting better in septic shock, think of source control. So if you have an abscess, if you have, cholecystitis that you're not draining or you're not operating on, and if you have an empyema, so all of these things will make the patient not respond. So think of source control, change your antibiotic. If necessary, you may be having a resistant bacteria. And then we have the adjunctive treatment, and I'll spend more time on this later in the next few slides. But adjunctive treatment, this is where the studies have looked at outcome by using the additional stress dose of steroid, which most people would use the 200 milligram per day or 50 Q6 of hydrocortisone. So this is sort of a quick checklist to help you decide if you're on the bedside and your patient's not getting better. Now, other problems, think of those, and these are things that can dramatically make a big difference. So some of you patients will be severely acidotic, whether it's lactic, whether it's other reasons for acidosis. So no matter what the cause is, if your patient's pH is less than 7.2, then give them bicarb. Although bicarb is not going to affect the overall situation, but fixing acidosis will make a vasopressor work better. So, give the patients boluses of bicarb. Sometimes we do infusions afterward. Look for autopeep. This is again what causes dynamic hyperinflation and preload reduction. And then the other things like high intra-abdominal pressure, think of intra-abdominal compartment syndrome. And this is something that, examining the patient on the bedside when your abdomen feels like a basketball. This is where I usually tell the resident you need to look for reasons for that. And finally, hypocalcemia. So you notice these two things you'll be able to detect by doing an ABG, because you can check for acidosis, you can check for ionized calcium, correct those. The autopeep is something you have to look on the ventilator. This is by examining the patient's abdomen, and overall, maybe this list will help you to save someone's life one day. With this, there is this sort of common feeling when we see patients with heart failure, they have septic shock, what to do about this. And I almost invariably, when I get patients transferred to the ICU, they'll be under resuscitated because they have heart failure. And so we didn't give them fluid. But I want you to think, based on studies, about a quarter of patients who have chronic heart failure die from septic shock. So it's one of the big causes of death in these patients, and managing patients with heart failure and septic shock is very common for us in the ICU. So we need to be aware that when it comes to resuscitating these patients, although we have these various forms of vasopressors, and you can see how each one of them work on different part of the receptors, is what people manage. But when it comes back to fluid, people tend to under-resuscitate because they have the term congestive heart failure. So I wanted to expand a little bit on this issue here and remind you, when you look at pre-fluid resuscitation, what are the hemodynamic changes? And the main part that we see here is what happened to the venous capacitance. So increased venous capacity, that leads to preload reduction. Although these patients have higher preload, and they tend in heart failure will have more venous congestion, but no matter what the pre-existing condition, these patients, when they develop sepsis, they get this vasoplegia or vasodilatation, and your venous capacitance increases. So whether you're starting with a bigger or a normal size venous, it's always get relatively dilated, and the patients end up with preload reduction. So the resuscitation will not matter whether the patient have heart failure or not, that you still need to fill the tank. So this is what I would say the interaction between the disease state and septic management. If we look at those, some of these variable MAP, SVR, heart rate, preload, and contractility, in heart failure, we know that you can have, this is like a patient with a pure cardiogenic shock. They have this low MAP heart rate, high preload, and high SVR. Now in sepsis, we see sort of different situations. We see preload down, SVR down, contractilities up. When you have heart failure and sepsis, now your sort of SVR tends to equal out. It's about the same. You have tachycardia, hypotension. Your preload, though, is low. And your contractility, somewhere between the two, this equals out and maybe about normal, but not enough. So when we look at these various drugs and their role in this combination of heart failure and sepsis, we see that norepinephrine would be the ideal vasopressor because it tends to help both contractility and the SVR, which is lowered by sepsis. Intravenous fluid would help with the preload reduction. So again, this doesn't really change anything when it comes to whether you have heart failure or you don't have heart failure. You still need to use Levophed, and you still need to give fluid. Now, inotropes, what most of us would go for, say, well, he's got heart failure, let's give him inotropes. The inotropes will have no impact. It will make the patient more tachycardic, although it increases contractility, but it's not going to help with your SVR. So a lot of patients, you never want to give them inotropes alone, and even if they have heart failure and septic shock, unless you can combine it with a vasopressor and give them adequate amount of fluid. So I hope with this, I I wanted to reiterate that the important with this combination of heart failure and sepsis, the treatment is still norepinephrine as your preferred vasopressor, and you need to give these patients adequate amount of IV fluid to resuscitate them, and do not be timid because they have heart failure. We do not probably have to go to the 3 liter, or what they call 30 mLs per kilogram, but a liter or 2 is still necessary in most of these patients. So other things when it comes to this sort of algorithm and again, some of these papers I'll be happy to provide to Dr. Kerala, maybe he can put on the website that I use for reference. But you notice here, vasopressors, we discuss on norepi, vasopressin. The problem with the vasopressin, it has no effect on patients' cardiac output. And it also is a very strong afterload, it increases the afterload of the heart. So it's not really a preferred agent in patients with pre-existing heart failure because it has no impact, and it's a pure vasoconstrictor. So in general, it causes afterload increase on the patient. Now, milrinone has an advantage. A lot of these patients are probably chronically on carvedilol or a lot of the remodeling drugs with beta blockers. So your milrinone would be better than dobutamine because it works in patients if they've been on beta blockers. And the next point is a lot of us see this entity, heart failure AFib, in septic patients, and then managing these patients, you won't be able to use diltiazem. Amiodarone is your drug, but esmolol is something that I will discuss in the next couple of slides. The digoxin should be avoided at this time. And again, if the patient gets better and they've been on beta blockers, then keep them on the beta blockers, even though the patient's hemodynamically, because that seems to help in their overall general outcome. So how many times of us have seen this scenario? Okay, your patient is septic, but however, he's hypotensive and he's tachycardic, heart rate 123, and he's AFib. And you're really sort of stuck. You push the levofed to increase the blood pressure, your heart rate tends to go up further, and then you're sort of in a bind between, more tachycardia lead to loss of this atrial kick and a loss of cardiac output. So this is a very common scenario a lot of us would see. And this is where it becomes, a difficult situation. So beta blockers for sepsis are something that, people look at and say, are you crazy? You're going to give beta blockers for sepsis? So I wanted to share with you a couple of the studies that were published. And actually, one is a meta-analysis, one is the original study. So this is the original study. Again, it's back from 2013. It's the Italian study by Morelli that looked at, the problem with the study is the open label design, but they looked at about 154 patients with septic shock. These patients all had to be on norepinephrine, and they had adequate fluid. You can see their wedge pressure more than 12. Their heart rate was more than 95. So they had tachycardia and septic shock. These patients were randomized to either receive esmolol or no esmolol. Esmolol was to control the heart rate, in addition to using norepinephrine. And if you look here, this is the control group where the heart rate remained above 100 on general. And this is the esmolol group where they were able to lower their heart rate and keep it between 80 and 90. And the study was done for 4 days. Now, what was very dramatic is if you look here at the outcome, this is the univariate or adjusted survival. So let's look at that graph. And you can see this huge drop in mortality between the esmolol group and the control group. And I want to say, a lot of people look at this and say, this is unbelievable. Why I'm not doing this on every patient? So if we look here at 28-day ICU mortality, and we see this significant drop here, almost 50% reduction between the esmolol group and the control group. So you can see this right away. The problem with the study, the control group mortality is very high. It's 90, 88, 80%. So this is much higher than any patients we would see these days. We wouldn't quote 80% mortality. However, their group looked at sick patients. They had a minimum dose of levofed, so they had to have all these criteria to enter the study. But again, this is very high mortality for the control group. So what study meant at that time, that the problem with it was open label. So the investigators or the treating physicians were aware which one is getting esmolol, was a single study center, and very high mortality in the control group. But the message when you see such a study is, look at the other aspect of it, that esmolol, if it didn't help, it didn't hurt. And patients did not do worse with esmolol, they certainly did better. And there is a lot of physiologic basis for sort of metabolic benefits of using beta blockers in the setting of hyperdynamic circulations and decreasing the stress on the myocardia and changing the metabolic benefit of beta blockers in those situations. So there is a strong physiologic benefit of using beta blockers. So from this study, there are a few that were done afterward, and I wanted to share with you this meta-analysis that look at the benefit of esmolol in adults with sepsis and septic shock. And this is published in June 2022. Again, we have about 8 studies that were all randomized controlled trials. You can see, looks like none of them were done in the Western Hemisphere. Some of them looked at mortality, some of them looked at other parameters. So if you do the meta-analysis and look at those studies where they used exclusively esmolol infusion, and this is the Morelli study, I highlighted it here, you see that based on the meta-analysis, there's a significant reduction, almost by 30% in the mortality if you use beta blockers in sepsis and septic shock. So this is a strong message that it is something for us to consider, particularly in a tachycardic patients with hypotension. And I know it sounds crazy to do when you have somebody who's hypotensive and you put order for esmolol, that there's a significant, there's a good number of patients that have been studied. Again, I don't see it in the guidelines. I'm hoping that there are some more rigorously done randomized control trials in this issue. So, and again, I welcome to hear any of the audience who use esmolol. Dr. Kerala put on the ICU Reach also the recent study. It was a randomized control trial that looked at the benefit of esmolol reducing vasopressors, and that was a small study, but it didn't look at outcome mortality. It was a small number of patients, and it showed that it did not reduce the number of norepinephrine equivalent dosage. So now we want to move, after we talked about these issues with how to resuscitate patients, how to provide adequate hemodynamic support, is to think of other supportive therapy for severe sepsis. And so again, and how the guidelines have changed from 2016 to 18 to 21. So I would say the major ones that we have at hand that has been debated and discussed at length, and there have been this circle of discussing whether to use steroids or to use vitamin C. So this is and if you look at steroid and septic shock, there have been trials in the past 30, 40 years, but the most recent were those 2 trials. And I'd like to, look at the outcome of those 2 trials that were a little different in design. And then the vitamin C, and we have several from the citrus ALI to vitamins to Ficta, and most recently, the one that was presented at the Belfast meeting, the Lovett trial. So I will discuss that one here at the end, and I will discuss those 2 trials for corticosteroid. So for corticosteroid, these were done. The 2 studies were. This is a very large database: 3,800 patients, 1,200 patients. We can see, and this is called the Adrenal Trial Investigator. So this is Australia, New Zealand. Famously, if you look at most of the studies published by this group, which are very rigorous, very meticulous, they all end up being negative trials. Somehow their large database tends, in my opinion, sometimes dilute the results, and we end up, most of the trials from the ANZIC group end up being negative or show no benefit. Now, the next one would be the European. This is Dr. Anani, who's published extensively on the use of steroids in septic shock. It's called the hydrocortisone plus the fludrocortisone for septic shock patients. So again, the timing, but both of these papers were published back to back in the same journal issue of the New England Journal of Medicine. If you look at the outcome here, this is called the adrenal trial. Again, the Australian, it's a multi-center, large database, mortality 27 versus 29, no difference between hydrocortisone and placebo by using the continuous infusion of hydrocortisone plus over 24 hours. So that was what is considered to be a negative trial or no benefit. The approaches trial showed significant reduction in mortality from 49% to 43%. So again, you immediately see, this looks like the study by the early goal therapy. We have a significantly higher mortality compared to this group of patients. And that may be a clue that in the sicker patients seems to be that hydrocortisone has more benefit than those patients who are less sick, because their control group had lower mortality compared to the control group in the placebo trial here. So we're not comparing apples and apples. I think we have two different category type of patients. Now, the two trials, this is the adrenal. What happened, even though there was no reduction in mortality, but the adrenal trial, we sort of shortened the time of shock by 1 day, and we shortened the time on mechanical ventilation by 1 day. And we know how much it costs to be in the ICU. And on average, it varies depending on the countries, but it's sometimes up to $10,000 per day. So I think, if you give patients hydrocortisone, which probably has minimal, if anything, value, by reducing the patient's only time of shock and getting them off the vent by 1 day, I think is a very big difference. And this is in the negative trial. The same thing was seen in the approaches trial. We see the vasopressor free was reduced by almost 2 days. The ventilator free days were reduced by 1 day. So both trials agree that if you use hydrocortisone in septic shock, you will shorten the duration of shock, vasopressors, and mechanical ventilation. And one trial showed decreased mortality, the other one did not. So in either case, I think most of us would aim to use hydrocortisone in septic shock, and certainly in those patients that continue to require vasopressors after a few hours of having escalating doses of vasopressors. So, and I think the 2021 recommend don't use it on all patients. I mean, many times we see patients on the floor before they come to us, they get septic and they say start on steroid. That's not the right recommendation. They have to come to ICU, they have to get started on vasopressors, get the adequate fluid bolus, and then if they don't respond and you can't wean that vasopressors, I would use hydrocortisone. The next would be vitamin C, and that really had a lot of excitement, and a lot of you would probably like to eat that orange, but I think this is how it was meant to be. I think we should eat an orange or two per day, but not have 100 orange squeezed and infused in our veins. Now the question is usually, is there any place for vitamin C in critical illness? And I think physiologically, if you look at what happened to turtles have the highest concentration of vitamin C in their brain, and turtles can tolerate hours of hypoxia. They can dive in, even though they're considered mammals, they can dive underwater and stay without oxygen for many times. And hence the study about doing vitamin C post-cardiac arrest. Again, I looked, and the study has been sort of supposedly recruiting for many years, but I don't see anything published. But physiologically, it makes sense that maybe vitamin C has some protective effect for the brain, and it has a lot of physiological benefit as an antioxidant. But what about septic shock? And this is, I think it's the main thing we want to discuss in relation to our lecture today. Physiologically, vitamin C is supposed to mitigate tissue injury and decrease oxidative stress. And since this theory has this came up in chest by the East Virginia Medical School. Dr. Paul Marek was the main investigators, and he's really became very famous from this study. He's using this cocktail. They called it the ATS, which is hydrocortisone, vitamin C, and thiamine for the treatment of severe sepsis and septic shock. So this is, again, retrospective, wasn't randomized, before and after study. And this study showed results that were sort of unbelievable. And when people say it's too good to be true, it's probably too good to be true. But I mean, you can see, I don't know, these were still available on YouTube, but you can go back to some of the publication or the posts on social media, particularly YouTube, in connection to this, where nurses said we were giving patients who were dying, literally dying from septic shock, this cocktail, and they survive, and everything get reversed in a few hours. It was really unbelievable how the nurses and some of the physicians were describing the benefit of vitamin C infusion. So looking at hospital mortality from 40% to 8.5. They were talking about patients very sick, maximum levo-fed, lactic acidosis, and not responding, and then including acute renal failure. So again, if you look here, this is like norepinephrine dose by using these patients and receiving vitamin C. We see how vasopressin get sort of weaned off in 30 hours compared to the patients that got the controls. So again, this is a retrospective study, not randomized. And that's the rationale for doing all these studies that I wanted to share with you. So from looking at this here, I'm going to concentrate on the last study, but all of these, the citrus ALI, the vitamin study, the VICTA studies, and I believe that vitamins was also presented in the Belfast meeting, the Glucare reviews, the citrus ALI. All of these studies were negative. The citrus ALI showed a sort of unusual results. It was done for patients with septic shock leading to ARDS. It didn't help the ARDS, but in that study, septic patient did better. It was sort of confusing results, but I think the next following studies made things a little more clear for all of us. So this is, I've took pictures of Dr. Merrick when he was discussing and actually criticizing the vitamin studies and how unhappy about the results and why the vitamin C study was negative at that time. So I think the most recent one published in this summer, New England Journal of Medicine, we see North Americans called the Lovett investigators and the Canadian investigators looked at using vitamin C in patients with sepsis. And this study published phase 3, multi-center, randomized, controlled, large number of patients receiving, they all had to be on vasopressors therapy in the ICU. And so when you look at the comparison, they use what has been considered the standard of care. If you're going to use IV vitamin C 50 milligram Q6 hours versus placebo. Now, this study showed sort of the, against all the previous studies, actually showed harm rather than benefit of using it. So if we look here at death or persistent organ dysfunction at 28 days, we see that vitamin C caused harm, and there was increase in mortality in those who received the vitamin C compared to those who did not. Again, this is more realistic. This is what I was about to say about septic shock outcome, that higher, the mortality is somewhere in the 40%, and we can see here the p-value was significant. So actually, vitamin C seemed to increase the risk of death or persistent organ dysfunction at 28 days. This is the Kaplan-Meier curve. Again, we see here 44 versus 38%. So it seems that placebo is better than vitamin C. And I was hoping by this study that we're probably going to stop doing the investigation, but there's still people that believe in it and are still criticizing every single study. But I think at this point, the preponderance of evidence tells us that we should not use vitamin C for managing patients with septic shock. So all of these studies are negative. Steroid seems to be helpful, vitamin C. So the statement in this 2021, and that's again, this statement was published before the Lovett trial. They recommended for adult with sepsis or septic shock, we suggest against using vitamin C. At that time, they said weak recommendation, low quality of evidence. But I believe if they were to review the recent trial, this will be thrown out, and I don't think it's going to be anyway in the recommendation anymore. So to summarize the bundles and what changes we've seen, 2018 sort of talked about combining what used to be in the previous guidelines called the 3-hour bundle and the 6-hour bundle. They made what is called the 1-hour bundle. So within 1 hour, they want you to do everything if you see a septic shock patient. Measure lactate, do blood cultures, start antibiotic, give 30 mL per kilogram for patients hypotensive or have lactic acidosis, and start vasopressors if the patient is hypotensive after fluid resuscitation. You got to do this in 1 hour. And I think as we discussed in the previous lecture, this is going to put a lot of stress because it becomes a quality measure for many of the hospital administrators, and they wanted to look at their quality. So there was a lot of pressure, particularly on ED physicians. Anytime you think hypotension, possible sepsis, hit them with antibiotic. And I think that was an abuse for antibiotic as they become a very cherishable item, and we're worried about drug resistance. So after this, the 1 hour bundle sort of being reviewed again and between emergency physicians and the SCCM, and then they put in January, so that was year after, they said, we recommend that hospital not implement 1 hour bundle in its present form in the United States at this time. So with this, I think the 2021 took care of that part, and they decided which patient should be resuscitated very quickly in 1 hour versus 3 hours. So the 2021 guidelines, and as I mentioned before, had those new sort of 93 recommendations, and basically they went over many of the aspects we discussed earlier, and they gave it a level of evidence or the strength of the recommendation. And again, as I said, I won't bore you with the 93 recommendation, but you can really read them in about 10 minutes. They're summarized at the beginning of their paper. So, but for me to summarize it here, I wanted to say that the new changes that we've seen is not to use QSOFA. We're going back to SIRS and sepsis and septic shock. And use, not in every place you can do serum lactate, but you can use capillary refill time to guide your resuscitation. We discussed the AMITA study that showed that it is as good to do this, probably best to do both if you can. And then, and the new recommendations say use early vasopressors, peripherally if needed. And then again, that's a new change. So you can run your levofed in a peripheral IV as long as it is in the distal part of the forearm and not waiting for having a central access. And then targeting the MAP pressure to lower, so we no longer need to go to above 60 to 65 seem to be an acceptable target that may lower the amount of vasopressors needed for the patient. When it comes to IV fluid, the recommendation, again, the magic number 30 mL per kilogram is downgraded to weak. So you don't have to give the whole amount. And dynamic assessment is better. And it seems we have more also evidence that using balanced solutions such as Ringer's lactate and Plasma-Lyte is better because of the chloride, unphysiologic amount of chloride given to patients during resuscitation is not helpful. And then the timing of the antibiotic, again, to sort this between 1 hour and 3 hour bundle, the recommendation, give antibiotic if your patient is in septic shock, so give it within an hour. However, if your patient having possible sepsis but without shock, then you have 3 hour window. And during that time, you should be able to get more data and be more certain whether are you dealing with septic shock or other causes for the patients to have the clinical manifestation of presentation. So this is what, the vasoactive agent management, again, norepinephrine, target 65. And then you can run your central axis peripherally, consider adding vasopressin, and then if you have cardiac dysfunction. This is a website that you can see it is through the British Medical Journal. So if you go to that link here, it will take you to that page. So it is for a lot of people that want to learn about the evidence. So it goes into every aspect of managing patients with septic shock. These data did not change. So when you hit on each of these boxes, it will take you behind to explain it and tells you what are the references. So for example, insulin therapy, we're targeting a glucose less than 180. No longer doing this aggressive glucose control, important about deep sedation. So it's really a nice overall how to best manage patients. And I think the reason we saw this reduction in mortality in septic shock over the years is not because we're doing this and that, because we're doing the whole conglomerate of care. Everything has improved, including how to ventilate patients, how to do to lighter the sedation, how to manage insulin and enteral feeding and so forth. So it's just not one aspect of care that the outcome of septic shock has improved. So I'll finish with the same principles that we mentioned before. In septic shock, you want to keep things perfused. That's your goal. And so you can manage this with capillary refill time, with serum lactate. You want to fill up the tank with fluid, and preferably using physiologic fluid rather than normal saline. Get the blood pressure up. The target is 65, and if you can use vasopressors peripherally, and do all of these quickly and concurrently. So it's not like you do one at a time and then let's wait how this happens. So it's sometimes, as we mentioned before, particularly with those patients with low diastolic pressure, start the fluid and vasopressors at the same time. So with this, I will end and see if there are any questions.
Thank you very much, Dr. Abouchala, for your very informative talk on sepsis again tonight. We're very grateful for you, so thank you. But just going to open up the floor now if there's any questions. If you want to raise your hand so we know who has a question to ask directly to Dr. Abouchala. And if you're not comfortable doing that, you can pop your question into the chat.
Let me start with a question. Nabil, do you know if the classic study looked at the subset of patients with heart failure?
No, I think there were, no, I don't know. I can't answer that.
And I thought, you know, they did, at least when I was in Belfast, they did not specify that they looked at this subset. I haven't looked at the paper itself, but I'll look into it too.
Yeah, that would be a good thing to review if they have this.
I was hoping that those kind of questions would be answered by the classic study, because you know the outcome of that study showed that there's no difference between the two fluid strategies. But maybe I was thinking that those patients with heart failure would have better outcome. So that would be, maybe we can contact the investigators to see if they can look into this.
Yes.
And the other comment I have, Nabil, is I know that they are still doing the vitamin C study in COVID patients. They are still recruiting patients. I think by the time the Lovett was presented, they had like 68 patients, and the plan is to go up to above 400 patients to see if there's really a benefit. You know, I heard that the data that was presented by Dr. Marek in the study 2017, it could be also flawed data.
I see. Yeah. You mean the chest study, the original one?
Correct.
Yeah, the one after. I see. Okay.
So there's a few questions in the chat. Firstly is one that maybe Dr. Carola can help with, but how can we have your lectures? I'm assuming we'll be able to record these and they'll be put online and then free to access for our members. Dr. Carola, have you anything to add?
Yeah, it will be available under Silver supporters to all. You can access it, but you have to be a Silver supporter to the ICU Reach.
That's great, thank you. And just to remind you, being a Silver supporter is $29 a year, and it's definitely worth it. Just to be able to access all this content in your own time to go over it. And
I want to mention also, Grace, if anyone would like to have free access, they need to contact you or me.
Perfect. So go ahead, contact either myself or Dr. Carola. So the next question is, what about microboluses? And that's from Musab.
Okay. Well, if you can comment what you mean by microbolus, I think the lowest volume recommended to see a hemodynamic benefit is at 250 mLs at a time. I don't think that's been studied. I mean, most of us, if we're dealing with heart failure patients, we probably won't start after giving the first liter, maybe we'll do after that 250 or 500 at a time and see how the patient responds. And best that would be guided with dynamic assessment, either the stroke volume variation through the arterial line waveform or using bedside echocardiography. But I would, what I mean by microbolus is I would say I don't think anything less than 250 would be meaningful to see if it has any benefit.
Thank you. The next question, my question is about antibiotics. How practical is it to not give antibiotics in pseudosepsis? Is there data for that?
I'm not sure. I mean, if you have somebody, it's always safer if you're thinking that the patient's septic is to give antibiotic. The bold decision is to decide, and this is where it becomes based on your confidence in this situation, is that if you did give antibiotic early and then you realized a few hours or within 24 hours the patient is not infected, not septic, then you really have to commit to stopping antibiotic. And that's where the de-escalation strategy or the committees that are built in recommended in many hospitals is to have a team to review the use of antibiotic and decide. And we get, in our hospital, a lot of messages from the clinical pharmacists say, do you need to continue antibiotic? Now you decided this patient had a massive PE, as in heart failure and so forth, it's not sepsis. So I would say I would aim toward more using them, using antibiotic when you're in doubt, but you always have to remind yourself, stop it. You don't even have to say, okay, well, he's better, let's continue. I mean, if he's not affected, it's not affected. But that's would be my approach if you're in doubt.
Thank you. Just looking at the Facebook, I'm not sure who has commented on it, but it says microbolus with 100 mils of 20% albumin using arterial waveform analysis was studied and it gave positive predictions. So I'm not sure what study that is from, but that is a comment that we've received on our Facebook.
Okay.
So on to the next question. It's got quite a few parts. So it's about esmolol. Do you personally use esmolol? And do you only use it in those with atrial fibrillation? And would you stop using it if it led to an increase in vasopressor requirements, or would you allow that? And what is the target heart rate that you use? Okay.
So I haven't used it frequently, to be frank about, but I think after reviewing the studies, I'm probably more willing to do that. I'm sure I'm going to have a resistance from our pharmacy, clinical pharmacists in this management. But if I'm going to use it, particularly in those tachycardic septic patients and those with AFib, would be to use it to target a heart rate less than 100. That would be my goal. And again, yes, if I ended up doing esmolol and then my vasopressor requirement had to go up and it's defeating the purpose, the studies have shown, at least even the study that Dr. Kerala posted on the ICU Reach, that it may not have helped, but it did not worsen the need for the Levophed or Levophed equivalent medications. So if it's not leading to increased use of vasopressors, then I would continue to use esmolol. If it leads to worsening shock, then definitely I'll stop it.
Nabil, I think Hassan would probably be able to comment on that many fluid challenges. Hassan, are you there?
Yeah. Thank you, Mazen. Yes, indeed. Hi, Nabil. Great talk, mashallah. Just to address Rumaisa's question, I think was so the mini bolus was studied in the context of echo. So you'll do VTI assessment. You give the bolus 100 ml, and you assess the response or the improvement in the VTI. And if the patient does improve, then that indicates your patient is fluid responsive. It's not enough to be done, unfortunately, with the arterial line alone. So the study was done in the context of echo. That's just to answer that question. Thank you.
Thank you so much for giving us a bit more detail about that study. Just now, the next question. Is there any trial assessing fludrocortisone alone in septic shock? And I guess it may be the combination between the hydrocortisone and the fludrocortisone that made the difference in mortality.
Well, I think that's been raised. I mean, the idea of giving mineralocorticoid in addition to hydrocortisone, and that was the original early Anani studies and the 2000, about the same time when the early goal therapy by Rivers were published. And so some people thought that this additional mineralocorticoids makes a difference. I think, you know, the largest number of hydrocortisone trials showed that it's not going to add much. So I don't think adding fludrocortisone is the reason for difference in outcome. The hydrocortisone by itself have a significant mineralocorticoid activity. That's my belief. I don't think we have, you know, any way to dissect it, but the reason is it's not the different protocol. I think it's a different type of patients.
Thank you. The next question is, are there any other studies about beta blockers to be used in sepsis with heart failure, such as using a different one like bisoprolol?
I'm not familiar with that. I haven't seen. I think that the reason we like esmolol being short acting and it's an fusion. So if you see any deleterious effect, you can discontinue it immediately. But I'm not familiar with that or of any publication for alternative drugs. And the problem then with esmolol being very costly.
Okay, thank you. Ali has his hand up if they want to answer or ask a question.
Thank you for a awesome presentation by Dr. Nabil. I will ask about occult heart failure or right heart failure as a cause of refractory septic shock in patients. How can we diagnose this problem apart from echo, and which criteria can we depend on? Or I know that Dr. Mazen nowadays is focusing on this problem.
Well, I mean, I think it's if you don't know the patient from before, you don't have a baseline echocardiography or prior history of heart failure. I mean, now I think we should aim for any patients who doesn't do well with the traditional, you know, if the doses of. So the way I suspect heart failure is when I start patients on vasopressors and give them adequate fluid, and I see the patients not improving, or I see that they're getting very tachycardic. That's a sign that you have a very limited cardiac sort of stroke volume, and the patient's the only way to raise the cardiac output by increasing heart rate. This is what we suspect the patient has LV dysfunction. So we usually do a bedside echocardiography. So I think nowadays echocardiography is taught to most people that work in the ICU to do it bedside. If you do, and most hospitals can request a formal echocardiography. But I think that would be the approach I would use if I suspected.
Nabil, I think Ali's question is more related to right-sided heart failure. Is that correct, Ali? By the way, how are you doing?
Yeah, it's correct. Yeah, I asked about right heart failure as the cause of the refractory septic shock. I am doing well.
Excellent, thank you.
Gracias for your question.
So for that, I would say it's a bedside echo. Those patients that, for example, you're treating septic shock for a non-pulmonary reason, and you'll see usually, I mean, you have to look at it in the right context, who may get pulmonary hypertension. So if I see as a patient with severe emphysema, the lungs are clear, and then you're treating their septic shock, and they're getting worse or not improving. This is a patient that may have pre-existing pulmonary hypertension for the chronic lung disease. Those patients that have obesity, hypoventilation, or untreated sleep apnea, also likely to have pulmonary hypertension. So it's the type of patients that I suspect may have pulmonary hypertension, but then I see they're not doing well. But most common reason for that is that severe ARDS patients that is overpeaked and have very high level of pressures needed for ventilation. Many times we end up, although we're supporting ventilation, but we may be hurting the hemodynamics. And that's the type of patients you want to do a bedside echo and see what happened to the RV.
Thank you. I don't know if it's a statement or a question from Nadia, but in acute heart failure, beta blockers are contraindicated.
I don't think they are, and it depends. I mean, we're dealing with systolic or diastolic. So beta blockers, we tend as soon as hemodynamics get better, for example, in cardiogenic shock, once the patients improve, we start them on these medications to work on sort of the stress factors for the myocardium. But I mean, this is different if you have sepsis with increased SVR, increased hyperdynamic myocardium, the beta blockers are helpful. If you have pure cardiogenic shock, then yes, I would not use beta blockers in those patients.
Thank you. So we have two questions from Mohammed. So firstly, what about the use of albumin in sepsis?
Okay, so regarding albumin, I haven't discussed it. I mean, there are quite a few papers. We have sort of a circle. Initially, there were data to show that albumin was hurtful, and then with worse outcome. And then we have the SAFE study that showed that that albumin was giving the same sort of outcome as other IV fluid, or what we call it, the colloid versus crystalloid. So that debate has been there. Now we see that colloids are safe to use, and that's what I call the SAFE trial. I think this is Dr. Carola here put the albumin in use in sepsis. So for us in real practice, we use albumin if I need to get somebody who's quite hypotensive, a rapid administration of fluid that I know that they can fill up the tank faster. But on the long term, it will not matter whether you give colloid or crystalloid. But if you want something acute and stays more intravascular, that would make sense. But understanding that the cost of colloids is, as compared to regular crystalloid, is significant. In the right setting, in patients who has liver failure and patients who have very low albumin, it's probably a good option. And if Dr. Carola wants to comment on these various studies here.
Yeah, we're just actually waiting for the ARIS study results. I'm not sure if they're going to be available later this year.
Okay, thank you. And the final question from Mohammed was, for patients with renal failure on renal replacement therapy, is there any role for special filters like Oxyris to absorb the endotoxins?
Right, so there's been some excitement on using these detoxifying filters with CRRT, particularly the polymyxin one, and that was published in the JAMA earlier. The most recent review of the literature in the guidelines of the 2021 recommend no use of these filters. I don't think there's enough evidence that they change outcome, and I'm sure they're quite costly. So what I can say is that there was no clear benefit. I don't know if anybody is using them. I'd be interested to know if they're available to some people.
Yes, Mohammed, if you have your hand up, you can speak. Go ahead.
Thank you, Dr. Abouchala and Dr. Muhammad Qasim. I'm a nephrology specialist. Actually, I was attending your lectures with Dr. Mazen in Syria like a decade ago. Actually, we have some cases with COVID. We used Oxyris for them. We noticed that the pulse rate or heart rate and blood pressure improved like statically and dramatically after using Oxyris. And the pulse rate was above than 100. Then after using this filter, we noticed that hemodynamic in general is become better. Noradrenaline dose reduce actually in very good shape. So we noticed this in many cases in COVID, but in sepsis, actually, we did not use that.
Thank you.
Well, I mean, I can't comment on this. I haven't had any experience with it. I mean, and their benefits, again, it depends on, you know, we need to see truly a randomized controlled trial to see if there's any more beneficial. But I wasn't aware that, so these patients that you use, was that in Syria?
No, in Dubai. In Dubai, I use it in Dubai.
Okay, okay.
Thank you. I've had a look on Facebook and there doesn't seem to be any more questions. However, the Facebook questions about microboluses were from Dr. Shanna, so thank you. And if anyone else has any questions, feel free to raise your hand or pop them into the chat. Questions about microboluses were from Dr. Shanna, so thank you. And if anyone else has any questions, feel free to raise your hand or pop them into the chat.
That's a delayed echo.
Very delayed. Did you hear the question? So if anyone has any questions, go ahead. Otherwise, yeah, I think that's all the questions tonight. So thank you very much. We're getting a lot of messages in the chat just saying thank you. I think we've all very much appreciated the hard work you've put into the slides and just how good they've been to watch and the graphics. So thank you for your time. And I think that's all for tonight. I'll just remind everyone, there's, again, if you weren't there at the start, we have a few advanced mechanical ventilator sessions next week. They're on the 31st and the 1st, so the 31st of August and 1st of September next week. And they're starting at 8 p.m. RIA time. And they're going to go on for 3 hours. And to be able to access these courses for free, you have to be a gold member. And that is $89 for the full year, and that'll get you access to other courses as the year goes on. If, however, you just want to access the courses for a one-off, they're $69 each. So thank you so much. Nadia is asking, how can we get free access? So if you go on to our website, which is ICU Reach, you'll be able to access lots of different parts of the website, which include our blogs for free. And there's also a few courses that you can access if you decide to become a member. So thank you very much for everyone for joining tonight. It's really great to have interaction and questions. So we very much appreciate it. So good night, everyone. Thank you.
Good night. Thank you.